For a woman wanting to get more information about the menopause online, especially on social media, she may be met with wildly differing opinions.
It's really about various conditions and hormone-related issues across women's health, where what hormones do to bodies long-term. We haven't studied these areas at all. We haven't done justice to research.
Just seeing the amount of controversy and the different camps of opinion, it can be really difficult to know what to believe and where to get your information from.
Look for where the information comes from. Is there commercial gain behind this information? Is somebody trying to sell me a product or a strategy because they want some gain out of it?
I still get lots of women say, do I need a test?
There's no point in testing a random blood test because you may be on the day producing very little estrogen. After 45, if you're experiencing any symptoms which suggest that your estrogen levels are dwindling, then actually go by symptoms, treat quality of life.
What does testosterone do for us apart from our libido?
So women who either have HRT or they don't have HRT but take testosterone, a subset do benefit for low libido and a subset benefit for fatigue, better energy levels.
So let's talk about dementia and what we know HRT can do and what it can't.
So again, controversial area. If I say one thing, I think a set of people will kill me. If I say the opposite, the other group will kill me.
Welcome back to the Women's Handbook podcast, where we discuss everything women's health from menarche to matriarchy. I'm Dr. Natalie Hutchins, and today we are talking all about menopause management controversies. Now, for a woman wanting to get more information about the menopause online, especially on social media, she may be met with wildly differing opinions from whether she should be taking HRT for her heart, even if she doesn't have symptoms, to whether it will protect her from dementia, to whether she should be on testosterone for symptoms other than libido, and there are so many more. Now, doctors have always disagreed on things in medicine, and this isn't new, but I think the difference now is that in the past it was happening behind closed doors, at conferences, in committee rooms, passive-aggressive letters to journals. But now this back and forth is happening online, on social media, in full sight of everyone. And I can imagine that if you're just trying to navigate the menopause and work out a path forward, it must be really frustrating. And I hear often women saying, look, why can't you just get your act together and sing from the same hymn sheet? Particularly as we're only just leaving the controversy of the early 2000s behind. So that's why I wanted to make this episode, and we're going to get into the controversial areas. We're going to try and understand why those controversies exist and hopefully give women a little bit more clarity on how to navigate them. So my guest today is Mr. Vikram Talulekar. He's a consultant gynecologist, a menopause specialist and a researcher. So let's get started. Hi, Vikram. Thank you so much for joining me today.
Thank you so much for having me.
So, as I was saying in the introduction, there's just so much controversy at the moment in the menopause space. Why do you think there is so much discourse?
I think there is certainly a lot of controversy, specifically in areas of women's health. And so there are always opinions which divide. What do you classify as a disease condition? What do you classify as physiology? Which group of women need help? And do they need medicalization, or are we over or under medicalizing a condition? And so always people will have differences of opinion. That's why there is so much controversy out there when it comes to social media or information sources.
Absolutely. Just seeing the amount of controversy and the different camps of opinion, it can be really difficult to know, what to believe and where to get your information from. What's your advice to women who are looking at this and just feeling more overwhelmed than when they came into a discussion?
Well, I think whenever they listen to something, they read something, they watch something, whether it's telly, whether it's social media, whether it's papers, I think look for where the information comes from. Say, for example, this podcast, the reason you're doing it, you want to make it easy for women to understand why the controversy arises, what is the rationale behind it, where do we go for good evidence? And that's what they should be looking for. Where does this come from? Is there commercial gain behind this information? Is somebody trying to sell me a product or a strategy or some sort of hormones because they want some gain out of it? Or is this based on some good evidence? There are randomized trials, there are big observational studies. I'm not looking at technical aspects mainly, but just the number of women who have actually been taking part in studying some sort of an intervention. And if it comes from a bigger body, a body that's well established, for example, societies like the menopause societies, we have big groups of researchers who are based in UK, abroad. You want to look at their quality of research and then say, this does seem to be a big body of research saying the same thing across the world.
Yeah.
And that's what gives you confidence that something is really scientifically true, while other bits here and there, small research studies coming from companies who often give the intervention, you have to question, is this cherry picking? Are they trying to say something which is not really grounded in science?
Absolutely. I think one of the things that women might say to that in response is traditional medicine, traditional science moves so slowly. And we've already got a dearth of information or evidence base in this area, and not just menopause, as you say, in women's health. There's already been a generation of women that may have missed out on hormones because of the controversies in the early 2000s. And we don't want to wait. We want to do something now. If I know that, fair enough, there isn't maybe much evidence, but I want to try, surely that's within my right to be able to do so. What would you say to that?
And I fully get that. I think you've raised a very important point about individual choice or informed choice. We live in a world where everything is fast-paced. And as you rightly said, research, good quality may take 5, 10, 15 years until we really have a conclusion one way or the other. And with access to more and more hormone-related technologies or hormone products, of course, there is a temptation. I want to go ahead because preliminarily the findings look very attractive for longevity, for other reasons. Individual choice should always be respected. I think what should be behind that is explain to the woman, these are the benefits from the limited research we have, but we don't know the long term, what happens. Are there any side effects? Are there any bigger risks? If you're able to digest this information, understand the implication, and then make a valid choice, I would like to go ahead. I understand there may be risks. Fine. Then that's an individual choice I would respect. But what sometimes happens now, which is a worry, is often there is a push for an intervention, whether it's hormones or technology, without good counseling.
Okay. So I want to go through some of the kind of the big areas where there is more controversy in menopause management. So the first one I wanted to talk about was testing. But perhaps before we talk about testing for diagnosis, testing for monitoring, can we just set the scene by talking about physiologically what the difference between perimenopause is compared to menopause in terms of kind of women's hormonal profile? And I think maybe then that will inform our discussion on testing.
So perimenopause is an entity shrouded in controversy and often still not well characterized or established. So if you look at the journey towards natural menopause, and we're not going to probably talk about things like medical or surgical or induced menopause here. This is a natural journey.
Yep.
A woman would generally be having her natural menstrual cycles, monthly periods, normal levels of estrogen, which kind of go up and down throughout the cycle, FSH, LH within normal range. That's before any menopause journey changes have happened. So that's premenopause. The first sort of event or the first phase where things start changing is the perimenopause. So you either go by menstrual cycle change, so periods may change, the cycles may shorten, cycles may lengthen, so there may be gaps between periods, or there may be onset of symptoms. So symptoms such as something is suggesting the estrogen levels are dwindling. So some may have flushy sweats, others may have dryness of vagina, still others may have just mood changes, headaches, migraines, and you can go on and on, almost about 20, 30 symptoms. If those start happening and you're kind of approaching your late 30s, early 40s, then that's perimenopause. Now, how strictly you apply the definition of menstrual changes is an area of controversy. So some purists will say, unless the menstrual cycle has changed, we will not consider this perimenopause, even if symptoms are happening. Others will say, no, menstrual cycles may change much later. The estrogen levels start declining up and down much earlier, maybe 5 or 10 years. And so you should be actually addressing this bit as perimenopause. So we are not finally down to a definition. You kind of take a holistic look and say, hormones start changing, some symptoms appear, periods start changing. That whole phase will be the perimenopause. And finally, a time will come when periods will stop. Very little estradiol coming from ovaries, very little progesterone. 12 months of not having periods, technically that will be menopause. And any time from that till end of life, post-menopause.
Got it.
So peri, then menopause, and then the whole rest of 30, 40 years of life post-menopause.
Okay. So as you were talking there about the up and downs, and so really to compare and contrast that bit, you were saying that post-menopause really is about being, frankly, kind of estrogen deficient, whereas in the perimenopause, often there's a kind of bit of chaotic nature to your hormones going up and down, and you may not be at one point estrogen deficient. So for women over 45, some practitioners will say, yes, we must test your hormones and we must keep testing them and see where you are. And then the guidelines actually say, we diagnose this based on symptoms. I still get lots of women say, do I need a test? What's your kind of take on that?
So we all see these patients who are very keen to know what's happening with their bodies. And I think I would go by the NICE guidelines here, because over the years, we initially did do a lot of testing. Maybe before NICE guidelines arrived in 2015, many of us tested for FSH levels, estrogen levels, but you could see that there was always no clear-cut correlation. So what we say now is what the NICE says, is we say after 45, if you're experiencing any symptoms which suggest that your estrogen levels are dwindling, then actually go by symptoms, treat quality of life. There's no point in testing at least a random one blood test, because you may be on the day producing very little estrogen, in which case I'll see very low estrogen, high FSH. But a week later, you might have a spurt of estrogen in the perimenopause, and you might be having normal estrogen, normal FSH. So where I catch you on that journey of up and down will give me a result, which may have no correlation to what your symptoms are. So we see women with quite a lot of fluctuation, having no symptoms at all. They're carrying on with their life with no problem. They don't need intervention. But we also see women with little bit of fluctuation having lots and lots of symptoms. And that's what you treat. We are here to help you with that symptoms, quality of life issue.
Absolutely.
So why do bloods? Because I'm really not basing anything on bloods here. I'm basing it on how you feel. And once you start feeling symptoms, that's the time to intervene, whether it's hormones or non-hormonal treatments.
Yeah. And actually, if you catch someone on that day when actually it looks like their estrogen levels and their FSH is fine, you may well actually unwittingly dismiss them and say, actually, nothing's wrong.
Correct.
It looks fine. Where instead of actually treating the patient and not the numbers. Yeah. I've seen a lot and I sent you this video, I've seen a lot on social media, and I think there are more companies coming out now with these monitors where you test your hormones on a continuous basis. So what do you think about those?
Interesting technology. Technology is always good when it helps with things, but we're not there yet. So continuous hormone monitoring has a role, not yet in terms of managing perimenopause or menopause. Again, for the same reasons that if you keep testing somebody's hormones during perimenopause, let's say they're going from premenopause to perimenopause, they start seeing the fluctuations of estrogen, FSH up and down, slowly declining testosterone in the background. They will see those if you do continuous monitoring. Is that going to change my management strategy? No, I'm going to wait till they have symptoms. I'm going to kind of use HRT or MHT for quality of life purpose. So at the moment, you can do monitoring, you can know more about your body, but it's not translatable into changing clinically actionable management.
Yes.
So what I want the companies to do, the technology people to do is to run it in very good testing settings. See what difference it makes to monitor somebody's hormones for a year or two. Does it mean that they have better clinical outcomes? Does it mean you can intervene early? Now, there are some conditions. For example, if somebody has premenstrual symptoms, somebody is very sensitive to progesterone, somebody has migraines, often this can help. So if you're continuously monitoring somebody's hormone and you see a pattern, at such a time, often there is a peak of estrogen, peak of progesterone, that triggers the migraine, or that brings on the PMS symptoms. That's very useful technology. Then you can try to modulate person's cycle or hormones to eliminate those peaks and symptoms. But you can't apply it to generalize for everybody in perimenopause, menopause yet.
Yes.
So I would refrain from that testing.
Okay, so sounds like it's going to be exciting in the future, but not quite ready yet.
Correct.
Okay, got it. Okay, let's talk about, so the woman who has been diagnosed, she's put 2 and 2 together, she's kind of worked out which symptoms she's having, gone to her GP, spoken about it, or menopause specialist, and then they have worked out together, actually, this does sound like menopause. Maybe she's decided to go on to treatment, maybe she decided to do lifestyle treatment, but whatever, she's managing it. And then what about those clinics which will say, okay, if you are going to go on to hormones, we need to now monitor your blood levels to see if you're getting enough. Is that the right thing to do or not?
In certain circumstances, exceptionally, yes, but not as a routine.
Okay.
So again, the same problem comes is often when you test somebody's bloods while they're taking hormones, the absorption of the hormones can be quite erratic. So depending on what time, let's say you take a tablet, you put a patch, you put a gel, you put a spray on your skin, depending on how hydrated you are, what you have eaten, how much is the absorption of the hormones, lot of stress variations, lot of other lifestyle related variations in our blood parameters. And then in perimenopause, you always have the background hormones interfering on top of the HRT. It's really difficult to correlate these in terms of the clinical outcomes or what you see.
Yeah.
So again, your best test to know if hormones are working is look at symptom relief. Because if that's not happening, it doesn't matter somebody is absorbing or not. You got to change something.
Right.
There are better tests for long-term monitoring. For example, somebody's bone density scan, somebody's lipid profile, to look at how much estrogen they are getting and how much benefit of HRT they are getting. So that's why we say routine testing to know how much you're absorbing is inaccurate. Now, if somebody is on HRT on the highest dose and is seeing no changes to their symptom, that's one place where you could have a little bit of usefulness from doing bloods.
Okay.
Because then you can test their bloods and say, actually, the estradiol is very close to 0. That means you're not getting anything in your bloodstream. Let me change the type or the route or the dose.
Okay.
So for women who have no benefits of HRT despite being on a good licensed dose, that's where we often say test to know if they're absorbing at all. Or those who maybe where we are thinking they're not compliant to know whether they are taking HRT or not. But other than that, in routine sort of testing, again, no role for monitoring HRT and how it's going for you with blood tests.
Got it. And so just going back to the point about the bones, if you were on it for that indication, then really it's about monitoring with a DEXA rather than bloods?
You do a DEXA every 2 or 3 years or sometimes even longer if it's all good. And that would give you an accurate description. Is your estrogen reaching the bones or not?
Yes. Okay, perfect. All righty. So let's move on from testing then. And let's talk about one of the ways that sometimes people will talk about managing early perimenopause symptoms. That is a bit controversial. So let's talk about the pill and its role, or the hormonal contraception and its role in managing symptoms in the perimenopause. What's your view on that?
It's a useful option. So in perimenopause, the difficulty is the background fluctuations in hormones. So if I give somebody a set hormone replacement therapy dose, it's never going to be the same on every day for that woman. Why? Some days she will have her own hormones in the background. So it'll be addition of my HRT and the hormones, maybe too much. Other days, the ovaries may not produce much at all. And actually, that HRT may not be enough on its own. So it's like a little bit of up and downs during perimenopause, often tricky to adjust HRT. It's much easier to do that post-menopause because what you give is what the woman gets. She's not making any more estrogen of her own. In those fluctuations, sometimes may lead to side effects in perimenopause. So people often get migraines, headaches, progesterone sensitivity, often get lots of breakthrough bleeding because their own hormones and the HRT is clashing. And in that circumstance, the pill may be a very useful option. Especially the newer pills, which contain estradiol instead of the synthetic ethinyl estradiol. Those pills, unless there is a concern that this blood clotting or thrombosis risk, women can now take the combined pill till 50. So if they're fine with that and you don't have a concern for blood clotting, they're fit and healthy otherwise, estradiol containing pill might be a very good solution because it gives you all the HRT benefits, cancels out your background fluctuation because the pill suppresses ovaries
Yes.
and it cancels out the background hormone fluctuation into menopause, making very little of your own hormones
Yeah.
jump into the HRT or the MHT, which is non-pill.
Yes.
So it might give you those 5-10 years, especially if you're hormone sensitive, as a very good option for some.
Okay. And can you just explain why the pill or hormonal contraception will turn off that fluctuation in the ovaries, whereas MHT won't?
So pills usually contain either ethinyl estradiol or the estradiol, and they contain a synthetic progesterone. And they are very much powerful. So the levels we often say are supraphysiological levels of these hormones. So whenever the body is given a supraphysiological strong hormone combination, it suppresses own ovarian hormone production.
So it turns the ovaries off.
Completely. Suppresses ovulation, which is why the pill has benefit of contraception.
Yeah.
So it's only going to give you the external hormones. Fluctuations from you will be cancelled out. While if you look at the MHT or the HRT, it's physiological replacement.
Yeah.
Mild doses, natural, we say natural, but mainly plant-based body identical hormones. Estradiol often combined with progesterone, if not a simpler progesterone. And so therefore, they are milder, they don't fully suppress ovarian function. That's why there is a risk of pregnancy, especially for women under 50. They don't suppress ovulations either.
Yeah.
And that's the difference basically between the two types of products.
Yeah. So I think a lot of women will be absorbing the idea that, okay, maybe they do work for ovarian suppression and that's a good thing, but I actually just want the natural hormones that my body usually produces. What's your response to that?
So I guess it depends on what you're looking for. So if you're looking for reliable contraception that comes from the product you take, not having to take it separately.
Yeah.
If you're looking for suppression of endometriosis, hormone fluctuation, migraines, progesterone sensitivity with a cycle that happens with, say, natural hormones, you have pelvic pain, fibroids. In all those situations, the pill is excellent. It won't give you heavy bleeding, breakthrough bleeding, which is a major problem with the natural hormones. So if you're looking for that sort of benefit, then the pill is excellent.
Yeah.
If you're looking for something that's more natural in terms of bleeding is not a problem, you're not having heavy bleeds, contraception is not a worry, you can have it separately. You're mainly looking at long-term hormones for bone, for heart, lessening the risk of blood clotting, lessening the risk of, say, breast cancer.
Yeah.
You're going for natural HRT, body identical HRT.
Okay.
It's marginally better than the pill there.
Okay. So it's basically individualizing it.
Correct.
It depends what you want, who you are, what your context
what your medical
is.
history is.
Yeah. Okay. Got it. Can we just talk a little bit, and you touched on it there a little bit, but the difference between body identical hormones in terms of your clotting profile, in terms of your cardiovascular risk, in terms of its metabolic side effects versus the synthetic hormones that you get in the pill or some pills?
So we know traditionally pill is associated with risk of blood clotting. That's why it's often contraindicated if you have risk of thrombosis, very high BMI, you smoke a lot, you're above 35, or if you have migraines with aura. These are classically thought to be no pill or contraindications because it has about, say, 4 or 5 in 1,000. I'm just generalizing. It depends on the age.
Yeah.
But let's say a ballpark figure of 4 to 5 in 1,000 sort of risk of blood clotting. And it's probably similar with oral HRT. So if somebody takes oral hormone replacement with oral estrogen, again, it increases your risk of blood clotting.
Yeah.
Now, that risk is not applicable to HRT taken in other forms. Say, for example, somebody takes estrogen gel, spray or patch, or they take the progesterone as a natural form, or dydrogesterone, or a Mirena coil. There is no increased background risk of blood clotting. So that risk doesn't apply. And that's the beauty of the modern hormones, is that women who may have some risk of thrombosis, they have a high BMI, they have some other problems, they're smoking, or they have previous thrombotic issues, you can counsel carefully and use some of the modern HRT because they will not, above the background, increase risk of blood clotting.
Got it.
And that means that we can now offer hormones to more women.
Do you think that the information about that is out there and everyone kind of in agreement, cardiologists with women with ischemic heart disease and rheumatologists and things like, everyone's on the same page?
That's one area where we have a consensus. I think everybody now agrees that non-oral estrogen and non-synthetic progesterone oral HRT is safe.
Perfect.
It does not above the background increase somebody's risk of blood clotting.
Yeah.
The only area where there was a little bit of sort of no consensus was, what if somebody has had a blood clot or they have a blood clotting condition in the past? Can you still use it? But actually, the more experience we're having now, recent papers suggest even in those high-risk women, you can use it and it doesn't seem to above average increase their risk of blood clotting.
Yeah, so can use it transdermally. Okay. Let's talk about another controversy, which is progesterone use. So women who do have a uterus usually will get estrogen and progesterone.
Correct.
Women who don't have a uterus will usually only get estrogen only. Now, again, on social media or on online platforms, there are women who will say, well, I want the benefits of having progesterone. I may not have a uterus, so I may not need it according to the guidelines, but I would like the benefits of progesterone, in terms of my sleep and things like that. So please can I have it? What's your answer to them there? And what's the evidence about using progesterone above and beyond endometrial protection?
So again, I think here individualized choice is what strikes or comes to mind. So women who have had a hysterectomy, they don't have endometriosis, don't have any endometrial type of pathology or cancer. They only need estrogen. Now, some women, even after having estrogen, have residual symptoms. They feel that they don't have the same stability of mood. They don't sleep well. And in those situations, sometimes adding progesterone, although not routinely indicated, does seem to help. Now, we haven't classified well which is this subset of women where giving progesterone may actually do some wonders for them.
Okay.
What we have to be careful about is counsel women, this is not standard practice because it's the progesterone which sometimes can impact mood adversely and it can have an impact on the breast cancer risk because it's the progestogen or the progesterone in the long term which can slightly increase that little bit of risk of breast cancer.
Yeah.
So if you feel the benefits you're getting from progesterone are out measuring that risk which you may get from taking it, then it's your choice.
Yeah.
But as long as that counseling happens and the women's make an informed choice, perfect.
Yeah.
If the counseling doesn't happen, that's when it's a little bit not right because the woman needs to understand there is a little bit of balance to strike here.
Yeah. That's really helpful. And I think any woman is wondering that could actually just take this little piece to their doctor and say, well, actually, this is what Dr. Vikram thinks. So, and can we have a discussion based on my own medical history from here? So that's really helpful signpost there. Okay, let's talk about something that really has been very controversial and is talked about in the media an awful lot, which is testosterone for women. Currently, the guidelines talk about giving testosterone if a woman has HSDD, so hypoactive sexual desire disorder. And women are saying, well, we've got testosterone receptors everywhere. Let's look beyond our libido. We're not just sexual objects. What does testosterone do for us apart from our libido? And of course, we don't quite have the evidence for that. So how do you approach that with patients? You've got a woman who is been diagnosed that she's in either perimenopause or menopause. She's come to you. She's been estrogenized. She's on a good dose. What are you saying to her?
I would give her a trial of testosterone. Okay. So again, this is where informed individual choice comes in.
Yeah.
If you go as a purist, as a scientist, and you say, I will only offer treatment that's recommended in guidelines because it's been proven beyond doubt, then you can only focus on low libido, the HSDD, or you might say energy. Fatigue is another one that responds well to testosterone. So women who either have HRT or for some reason they don't have HRT but take testosterone, a subset do benefit for low libido and a subset benefit for fatigue, better energy levels. Those two are clinically evident in clinics when you do day-to-day clinics. The ones we're not sure about is impact on mood, cognition, brain fog, stability of how you feel most of the time, the concentration. Now, some women do report these outcomes. So when you see them for a follow-up after testosterone initiation, they come and say, I'm actually performing much better.
Yeah.
The worry is this a temporary effect like placebo for 6 months or 1 year, which is well known with many HRT studies? Or is this really something that these women have more receptors in their brain perhaps, and they need testosterone because it's going down slowly in the background? Recently, there has been a paper saying the levels actually go down from the third decade, little by little by little, and there's no much more drop at menopause.
Right.
Unlike the estrogen, progesterone, which profoundly drop once perimenopause, menopause happens, you don't see any excess drop at menopause. It's been happening since 30s.
Right.
So why would you have symptoms of testosterone now? That's the question from the purist. But you do find that some women report clinical benefits.
Yeah.
My gut suspicion is actually in future, we will have studies which will report more positive outcomes from testosterone use.
Okay.
So when
is that
you
what
have
you're
those,
seeing in practice?
Correct. So when you see randomized trials in future or big observational trials, I feel that we will probably add to benefits of testosterone, like the brain fog and the mental acuity and the mood. But we don't have it now. So again, careful counseling is important. Say to the woman, we don't have data. If it's for libido, for energy, this might help. So you always have a try, have a good blood test initially to say you're already not running a high level. That's the only reason to do the test or blood test. Then have the testosterone for 6 months. If it makes a difference, carry on. And we do one more measure that you're not getting too much. Otherwise, come off after 6 months. Now, we recently audited our own clinic data and found by 3 years, only 50% of women were continuing.
Interesting.
50% had found no benefit or side effects and stopped.
Interesting.
So there is a group which does benefit and consistently would benefit, but we haven't yet figured out who it is. It's not for everyone.
Yes. Okay. Can we just touch on what you were saying about the testing there? So when you talked about testing, you said quite specifically, we're only doing this to see if you're not above the physiological level. Talk to me about that, because there will be women who have gone to clinics who come in with a bit of paper and they say, look, my testosterone is really low and that shows that I need it. So it's not really about my symptoms. It's not that I don't feel well. It's that someone's tested my testosterone and it's in my boots. So can you give me some treatment?
So that's
what would
not
you say
accurate
there?
based on the current science. If somebody has a test in absence of symptoms and you pick up a testosterone less than 0.5, that's usually the range you will get. That doesn't mean they're low in testosterone. Many of the assays commercially used were never designed to pick up the low levels which are normal for women. And these were tests designed to detect the high levels which are usually found in men.
Okay.
And so if somebody does a test and it comes low, less than 0.5, the lower limit of the assay, it doesn't mean you're deficient and you need testosterone.
Right.
It's again the symptoms, because for many women, that low level will be fine. The testosterone comes from two sides. You've got your ovaries, but you've also got your adrenal gland. So although you lose the ovarian testosterone after menopause transition, the adrenals are still producing testosterone.
Right.
Unlike estrogen, progesterone, where ovary is the only source and it's gone. So for many women, that adrenal testosterone will be enough lifetime. So testing doesn't help in that measure because the assays are not accurate, and also it doesn't correlate with symptoms at all. The reason to do blood test is some women may already be running high, like they have PCOS, they have other generally high testosterone right from birth. In that case, if they're running relatively high testosterone, I'm going to say it's probably no use taking more testosterone because the level I'm aiming for, you already have it naturally. That's the reason to do the test, to kind of counsel saying, I don't think this will help. And again, to do one more level after starting to make sure that they're not getting too much. Some people absorb quite a lot of testosterone. They will have acne, oily skin, hirsutism, alopecia. Then if the level comes too high, I might say use half of what you're using now. That's the second test.
How often do you find that women will have side effects like acne, like oily skin, even though they're still in the physiological range?
Very, very less common. So it's all, if you're taking the right amount and you're absorbing what we expect, and you're kind of having a couple of bloods which show you're kind of hovering around the middle or towards high side of the range, which is expected. I don't think anybody I've come across will have the oily skin, the alopecia.
Yeah.
The trouble comes is for some, they absorb a lot. So on the test, if you find they're consistently showing above average level, and if you continue with the same dose, they will start noticing some of the side effects. So you have to drop the dose to a little. Some feel so good that they start using more.
Right.
And that's something definitely not advisable, because you may feel better, but you'll start noticing the skin and other side effects.
Okay. Maybe also, could you just explain why often doctors will say, let's start the estrogen first, get you sorted on that before we start thinking about testosterone adding in. Why do doctors tend to approach it in that way?
Because it makes a sort of physiological sense to follow what has happened. Most remarkable changes in hormones at menopause are estrogen, progesterone. So if you correct that, many women will never need testosterone. So the moment you correct good enough estrogen and you've actually got your HRT working well, many women will not report symptoms which we think of testosterone use.
Yeah.
And that may be the primary reason why they are having some of the symptoms. So if you directly go for testosterone, you might be defeating the purpose, because actually you're giving only a hormone that's taking care of one or two symptoms, while you've not actually treated the main cause, which is lack of estrogen, which might have corrected it anyway.
Yes.
So the more rational way of saying is, let's correct the hormone which is the least, which is estradiol, combine it with progesterone if you need endometrial protection. If that then leaves you with a couple of symptoms which we think are testosterone, go ahead as the next step.
Let's talk about, this word is a very buzzword at the moment on social media, online, HRT or MHT as a longevity drug. So maybe let's start with the big one, because cardiovascular disease is the number one killer in women in most countries. What do we know that is not controversial about MHT in women, and what do we think is still controversial?
Okay, so if you look at cardiovascular disease per se, a lot of confusion, as you know, happened when the WHI studies came up 20 years ago.
Yes.
And part of it was because many of the women who were participants had already had underlying comorbidities and medical problems. And on top, they were giving HRT in oral form, which we know is slightly blood clotty, so can increase blood clotting risk. So those results kind of brought out the information that HRT can cause heart attack risk. So stay away from it. Yeah. That's not applicable now. Modern HRT is very different. The doses are different. We use usually transdermal HRT. Unless somebody is completely without any medical problems, you can always use oral HRT as well until age of 60. But generally, let's say for somebody with some risks, overweight, smoking, or some cardiac risk, we will always use transdermal HRT. We'll use a progesterone which is more body friendly, like dydrogesterone or the natural progesterone. And in those settings, HRT has very little risk for heart disease at all. So I'll quickly summarize in 2 lines. If somebody takes HRT after having gone through natural menopause after 45, and they take it until age of 60 or within the first 10 years of having started their menopause, stopped periods, they will have some benefit for their long-term heart risk, less risk of heart disease.
Yeah.
Now that risk lowering is little. It's not a big impact. Yeah. So something like if 100 women take HRT, 1 or 2 might have benefit for their heart disease risk reduction. But anything is welcome because it's an extra benefit of HRT.
Yes.
If somebody starts HRT after 10 years, after 60, you don't see that benefit because some of the changes of menopause in the arteries and the heart have already happened. But of course, you're not seeing some extra morbidity or heart risk. So you can still have it after 60, but you will miss out on that 1 to 2 in 100 benefit, which you might have for the heart disease risk reduction.
And are those women that have symptoms? They're on HRT because of symptoms, right?
Correct.
So in women that have symptoms of the menopause, if you go on to HRT within that 10-year window, there will be some benefit to your heart. Okay. What do we know about women that don't have symptoms?
Very little. So we know very little because usually MHT or HRT has been used in healthy volunteers, not with any major medical problems, not with established risk factors, because you often go for a healthy population whenever you do a study.
Yeah.
Why? Because as I said, 100 women will have to take it to get that 1 or 2 women getting that possible benefit. You're far better off probably doing lifestyle, exercise, diet, controlling lipid profile, diabetes, not smoking. All those things will be much, much more stronger determinants of your heart disease risk than solely relying on HRT.
Yes.
So for primary prevention, we don't have enough data, but we know that HRT has benefits for heart. So if you're symptomatic and you take it, you will get some benefit from it.
Yes, which makes sense because if you're symptomatic and you're feeling awful and you're not exercising and you're not being social, you're not eating well, you're not sleeping well, it makes perfect sense, doesn't it? I was doing a podcast just yesterday with a really good friend who is a maternal fetal medicine consultant with research into the long-term effects of pregnancy complications on women's long-term health. And we were talking about, pregnancy being a stress test and being a good window into someone's future cardiovascular disease risk profile. By the time someone gets to menopause, they've already got perhaps changes because of their gestational diabetes or preeclampsia or the fact that they smoked or their genetic risk. So you're bringing all of that into your midlife as well, aren't you? So then hormones are just one part of it.
Correct.
Okay.
There is so many variables impacting heart disease risk. It's very difficult to actually pick them apart one by one.
Yeah.
All you can say is, if I'm symptomatic and I'm having HRT and I start early enough, I'm going to have some benefit potentially, but not guaranteed. If I start later, maybe no benefit, but no risks, no extra risk. But just for the sake of heart disease risk, I wouldn't take it.
Okay.
I have to have symptoms and then take it and reap the extra benefit.
Now, is that latter point slightly controversial? Because there are some Royal Societies or guidelines which say you might be able to consider it for primary prevention, or they say something like that. It's not a definite no amongst all societies, all guidelines, is it?
Of course, there will be variation in guidelines, variation in individual opinions, which is how we started the podcast. So if you look at the standard guidance, say from big bodies, which are kind of authorities in the space, they will still say, no, we need more data before we can say HRT for primary prevention. So where we stop at the moment, say in UK, for example, we say, no, if you're not having symptoms and you're not taking it for quality of life, purely for purpose of heart disease prevention, it's not a standard to give you HRT. Now, some women may have a higher risk because of family reasons, genetics, their past medical history, and may say, I want to take it. That's an individualized decision for that particular patient.
Got it.
But when you look at guidelines and recommendation, they have to look at the whole population. Is this worth considering as a primary prevention? The benefit looks to be minimal if you let the population scale. And of course, there are risks like breast cancer from HRT, whatever little risk. And the balance doesn't still completely go in favor of HRT as primary prevention. That's why there is the difference in opinion.
Yes, got it. Okay, let's move on to dementia, because this was, caused quite a big furor a couple of months ago, or whenever it was that the FDA kind of changed their black box warning on estrogen. So let's talk about dementia and what we know HRT can do and what it can't.
So again, controversial area. If I say one thing, I think a set of people will kill me. If I say the opposite, the other group will kill me. So to kind of keep it where we know what we know so far. Looking at the results about looking at dementia risk and taking estrogen in HRT, there's no conclusive evidence one way or the other. So one group said, if you give HRT and start it relatively late, you can worsen dementia risk. One group said, no, if you give estrogen to anybody in midlife or later, it's very good for brain, very good for prevention of dementia. Many people sit in between because there is this worry about worsening dementia risk, and there is some evidence that it could benefit subset of women. it's a bit of a clash and we don't have a conclusive evidence one way or the other.
Got it.
Certainly for women with premature menopause, early menopause, those with a gene risk like the ApoE4 gene, there are good observational studies which suggest that you can reduce their cognitive decline risk later on in life. For women who have no genetic risk and are beyond 45 with a natural menopause, right now we have to say it will neither increase your risk nor we have evidence it will protect you.
Yeah.
And it's the lifestyle, the same thing as we say with heart disease, that will be the key to make sure you have a good lifestyle to prevent your risk or minimize risk of dementia.
Yeah.
If one designs a very good quality research in future, a study over 5 years with modern HRT, and then looks at long-term outcomes even beyond that for 10, 15 years, you say that we can't recommend it only for dementia prevention. We just need more scientific rigor and evidence.
Okay. What about the woman who comes to you and she says, I am really into health span and longevity. I exercise, I eat very well. I actually don't have many symptoms, but I am interested in taking it because I believe it's going to extend my lifespan.
Okay.
What evidence is there that it reduces mortality?
So, not much. Very little HRT research has happened in the 6th, 7th, 8th decade and onwards, because women were usually restricted to having HRT for until 60, 65 traditionally.
Yeah.
It's only now that we're actually extending to 7th, 8th decade or end of life. So because of lack of research, we don't have any conclusive data. We say that HRT does not increase mortality, so that's definite. Taking HRT doesn't mean it will cause you to die early.
Yeah.
Does it extend lifespan? We don't have data. Yes, it's very good for bones. Yes, it's very good for heart if you start early. Yes, it may have some benefit for cognitive health, but we need more data. It is good for metabolism in general, but we don't have any conclusive data to say it will make you live longer or it will make you live longer healthier. Yes, indications are there, but no scientific data on paper, because you would have to wait for many women in their 70s, 80s to have enough HRT to be able to comment on that sort of a outcome.
Yeah.
So when women come and say, I want to take this for longevity, again, it's their individualized choice and it should be respected. But they need to understand there is very little data beyond 65 or 70 for what are the ongoing benefits and risks of HRT. And of course, does that mean they will live longer purely because of it or no? We need much more evidence for that.
Yeah. Okay. There are, as we said at the beginning, there are a cohort of women who were scared of taking HRT, 5, 10, 20 years ago now, with all the controversy, who feel they've missed out. And perhaps maybe that woman is now 70, maybe she's still having some symptoms. Can we talk a little bit about that? Because sometimes that gets a bit confused as to whether or not you're able to start HRT that far out. Yeah.
And I would certainly offer those women HRT. I think we've done injustice to women, at least for a couple of decades, where a lot of women who could have really benefited from HRT lost out because of the negative publicity, the fear among health professionals and public. So I think if they have some symptoms now, and if estrogen could help with some of the symptoms they have, whether it's vaginal estrogen, systemic estrogen, they should consider HRT. And with the modern preparations, we have very little risk, as long as they can balance out their benefits against the small increased risk breast, for example, then of course they should have HRT if they want to go ahead.
Got it. Okay, we've talked the whole thing about controversies, but why don't we just spend a little bit of time talking about what we definitely know, what there is really good consensus on, so that hopefully women are definitely not confused about these bits.
3 things.
Okay.
POI, early menopause. So under 40 or under 45 is premature or early menopause. These women should really consider HRT. Okay. I still see women who are diagnosed late or misdiagnosed when they don't have periods when they're young, often thinking PCOS or stress. But actually, if they've had a cycle change more than 3-4 months, should do FSH. This is the place for blood testing. Make sure you don't miss a diagnosis of premature or early menopause. Because HRT is gold standard for these women, unless there is a contraindication like hormone-sensitive cancer.
Okay.
But for everyone else, HRT till 50-51 will make sure they don't have any cognitive, heart or bone problems later on in life.
Okay, so when we were talking about testing earlier, really that was applying to over 45, but if you're under 45, it's really important that you get that testing. Okay.
Ethnicity, again, keep watching the patient in front of you. Remember, all that we talked about is about Caucasian women data, very little research, very little understanding about menopause in Asian women or Afro-Caribbean women. And often they may need earlier intervention because the menopause may happen earlier and the presentations may be different. Their bone, their heart risk may be slightly higher. We need good research on this, but consider the patient in front of you. If they are a different ethnicity, maybe don't apply the same rules. Be more sensitive to the needs.
I understand that Black women will tend to have their menopause earlier. They may have more vasomotor symptoms, so more hot flushes and things like that. And women from the Indian subcontinent, they will also have menopause earlier, perhaps even earlier than Black women. Is that right? 4 or
5 years earlier.
Yeah, really early.
And so that means their heart may be needing an earlier intervention because they're losing estrogen early on in life. They already have a high risk of diabetes. So again, more intervention from cardiovascular perspective. They may be symptomatic earlier and often that gets neglected as, oh, this must be stress, this must be life because you're maybe 41, you're 39. So just being a little bit more sensitive to say if it's a different ethnicity and they're presenting like somebody white presenting at 45 or 50, think of menopause, think of perimenopause rather than medical conditions.
Absolutely. And for the women themselves, if you start feeling off and you're in your late 30s, if you're Black, if you're
have a discussion
Asian,
with your GP.
Exactly.
Correct.
Yeah, okay.
Absolutely right. Second one is about the bone health. Estrogen is amazing for bones. Now, for women who go through natural menopause after 45, are reasonably having a healthy lifestyle, having vitamin D, either as supplement or having a good level because of exposure to sun, for example, having good calcium in their food, not having any deficiency, relatively physically active, they would be able to maintain their bone density even with just lifestyle measures. But if they have a risk factor, they must go to their GP because once the perimenopause, menopause starts, if they have a risk on top, either family history of osteoporosis, they're smoking, they've had early menopause, or have steroid treatment, then
eating disorders.
Absolutely. In which case they will have a significant risk of osteoporosis. So going in early, considering either HRT or non-HRT management of osteopenia, osteoporosis prevention is key.
Okay.
And the good news now is with the National Osteoporosis Guidelines, HRT is a first line option for women who are worried about osteoporosis or are treating it alongside non-HRT options, which used to be much restricted before under 50, but now up to 60, you can have it as a first-line treatment option.
Brilliant.
So think of your bones, make sure you're doing bone-healthy lifestyle, weight-bearing exercise. But if you have a risk factor, go to your health professional, maybe have a DEXA scan that will give you more idea.
Got it. Okay, that's great.
Final one is menopause and cancer. This is a group that doesn't get the support that they should.
Absolutely.
Cancer-related menopause can be very difficult because you have sudden chemo and you're menopausal in weeks, or you have ovarian surgery and you're menopausal in 24 to 48 hours. One day you have hormones, the next day you don't. And that can be really big shock to the system. Lots of symptoms, persistent symptoms, and sometimes the cancer means you can't have hormones.
Yes.
So this is a group of women who needs a lot of psychological but equally clinical support. There are lots of good organizations now outside in terms of charities which help in this situation, but equally talk to your health professional and maybe push them a bit because there really has to be a good MDT sort of support from the GP, from the cancer specialist, from the hormone specialist. And the plan should really be in place before you have your surgical or medical menopause. So your HRT, your non-HRT plan should already be done. The moment you start experiencing symptoms, they're looking after you, your bones, your heart, your brain.
Are you able to say something about vaginal estrogens in that group of women?
we're big fans of vaginal estrogen. Vaginal estrogen has very little risk. The amount that's absorbed in the circulation is so little, especially from the low dose preparations we use now, the pessaries or creams, is that actually there is no risk, even in women who have had hormone sensitive tumors. With appropriate counseling, we can use vaginal estrogen. There was some scares about using it in women with breast cancer on aromatase inhibitors. But actually, the data overall, if you put 2 + 2 together, does suggest that as long as women know what were the problems with the studies, as long as there are quality benefits for quality of life, for the vaginal health, and you've tried your first line non-hormonal treatments or other treatments and it's not really getting anywhere, you can still use vaginal estrogen.
Good to
It's
know.
minimal risk, very safe, and you can do it with supervision from both the oncology and the hormone team.
Any other certainties that you're just like, this is absolutely a kind of a must for women going through the menopause?
Well, I think information. So watch your periods, watch your symptoms. Help is out there.
Yeah.
Don't be worried about hormones. They're much better and much more sort of physiological now as they were 20 years ago. Different hormones now.
Yeah.
Equally, don't be pushed into having something which you don't need.
Yeah.
We need much more data to say this is longevity solution.
Yeah.
Much more data about testosterone, dementia, risk prevention. So until we have good, robust scientific data, keep it simple. Use it for quality of life, use it for symptoms, some indirect heart and bone benefits, and balance that against risk of breast cancer, because that's equally important that you know what could be the potential problems. But for majority, the benefits will outweigh that risk.
Absolutely.
So that information, good discussion with your health professional, that's the key.
Absolutely. And that's really good advice. And I think something I'm seeing more and more of is women going, oh, Natalie, I feel fine, actually. I'm doing quite well. You know, I'm exercising, I feel good, and I'm managing my symptoms, but I don't want to miss out. You know, and I'm going, well, no, actually, I don't think we've got the evidence to say that you're missing out actually on anything. And there's that kind of anxiety, like everyone's talking about longevity and heart health and dementia prevention. Maybe I'm missing out on this. It's good to have that message that, you know, this is a balance, it's individualized, it's not a one size fits all. And certainly we don't have the evidence to say that everyone must be on it.
Absolutely. Not everyone needs HRT. The place where it should be given and can make a difference, one shouldn't deny it.
Yeah.
That's how we look at it.
Yeah. Yeah. And the one thing I suppose that we do say is a must for everyone is thinking about your lifestyle.
Absolutely.
Which is what we've talked about as well in there. Amazing.
Perfect.
Thank you so much, Vikram. That was a great
Pleasure is
conversation. I hope it will be very useful to everyone listening. And that's it from us at the Women's Handbook Podcast.
Thank you very much.
Awesome. Thank you so much.